All right, so this is Clin Farm 2. Congratulations for making it through 1. Your concerns were heard in the evaluation, so we decided to double the number of lecture hours for this class. So 64 instead of 32, so no squeaks, that's good.
Excuse me, I'm sorry.
Oh.
There's a card issue. Somebody have a light tan Camry.
Okay, so everyone found the lecture uploaded last night, and the syllabus is up there. Syllabus is pretty much the same. This is going to be very similar to Farm 1, it's just different subjects we're covering. Certain drugs will come back and make a reoccurrence, so you don't want to go and dump everything you learned in Farm 1. Hopefully you haven't done that already. And then in this class, since there's more lecture hours, we're going to be dividing it up into 4 exams that will be equally distributed throughout the semester. So any questions on that? Nope, okay. Sounds good. And this will be basically every Tuesday, Thursday from here into infinity as far as we're concerned, right? So it'll be nice and at least spread out over a longer period of time, because that was another one of the concerns with Farm 1, was it was kind of truncated a little bit just because I was still new and coming on and had an extra class and all of that. So this will be nice and a little bit more, give you more time to kind of digest the material before having to kind of cram for the exams. Cool. So the first section we'll be covering today is going to be our OB-GYN. Keep in mind, I barely know how women operate, how they work. It's amazing that I've even been married for this long with how often I stick my foot in my mouth. So I'll try to answer any questions you have, but I may have some limitations to all of that. So just keep that in mind. Okay. The first thing we'll talk about are going to be concerns with pregnancy and lactation, and talk about how medications can either be affecting pregnancy and lactation. We'll also talk about some of the complications of pregnancy and some of the medications that we can use to treat those patients, and what's kind of safe for them, and some of the medications that we should be avoiding. So, who's heard of thalidomide? Okay, what's the big deal with thalidomide? Major birth defects. So you can see these kids here, they had basically have malformed limbs due to use of thalidomide. Originally, it was used as an anxiolytic over in the UK. This is back in the late 50s, early 60s. And so they were kind of used as a kind of a sleep agent for some of these pregnant women. And then all of a sudden they started having these fetuses were born with really just kind of malformed limbs. And so fortunately, we didn't really have too much use over here in the US. That was never FDA approved over here due to some of those safety concerns. But this led to a lot of the regulatory requirements around new drugs being put out in the U.S. And so there's this FD&C Act, which is the Food, Drug, and Cosmetic Act, and that's basically the big overarching law concerning drugs, foods, cosmetics that are used in the U.S. It's a very old act, but we make new amendments to it as time goes on. And so this is where this Kefauver-Harris drug amendment came about, was due to the concerns with thalidomide and saying that, well, we should probably test these medications to make sure they're both safe and efficacious prior to putting them out on the market, right? So before, you didn't necessarily have to prove efficaciousness of the medications. You could just kind of say, okay, they appear to be safe, let's go ahead and use them. So fortunately, these are good laws that come about due to some unfortunate consequences of drug use in some of these patients. So I think only like 6 or 7 children were ever affected here in the U.S. Most of it was over in Europe. So we know that drug use during pregnancy is pretty common. You can see here that the rates are actually increasing. So you can see in this blue line here, this is the percent of women who are at least taking 4 or more medications at any time during pregnancy. That's not all at the same time. It could be, some Tylenol here, maybe some some Zofran there, things like that. But it's increasing. And then especially if you look at that red line, that's the number of women or percentage of women who are taking 4 or more medications during just the first trimester. And so why do you think we make that differentiation there? Because they may not know they're pregnant. May not know they're pregnant. Also, when does most of the organ generation occur? First trimester. So this is kind of the most critical time period where drugs can come in and have some deleterious effects on the fetus. And so this is a really important area. And just like you mentioned, a lot of women may not know they're pregnant during this time frame. So you can have the effects of things like alcohol, nicotine, and other routinely used prescription medications affecting the fetus without the mom even really knowing it. And so they also report that at least 90% of women are probably using at least one medication during pregnancy. And if you were looking at the most common ones, this probably makes sense based on just what are the most common medications in use in the home. And so you look at over-the-counter medications, things like acetaminophen are used very, very frequently for pain, headache, fever, things like that. Ibuprofen used less often, but probably second most frequent, and then also pseudoephedrine, used for a lot of cough and cold complaints and things like that. So very frequently. Do you think any of these are particularly dangerous in developing fetuses? We'll find out. We'll find out more about that. Probably not, but it will depend. You'll see that certain drugs may actually have different effects on the fetus at varying stages. Specifically things like non-steroidal anti-inflammatory drugs like ibuprofen, we'll see how that can have different effects and actually has a different pregnancy category based on when it's being used in the mother. We'll also see, and this is really important because I think that as time goes on, we're starting to recognize postpartum depression. We're starting to recognize mental health issues in pregnant women more frequently. It's not has a negative stigma attached to it, and so we're starting to see antidepressant use being used much more frequently than before. So say even between 1998 to 2005, see that the increase is going up, around 4 times as many women are using antidepressants, which is probably a good thing in the long run because, again, if you are having issues with the mom, that can directly affect the fetus, right? A lot of times when we're in the tox world and we have, say, a pregnant mom who has tried to commit suicide, a lot of times you wonder, well, what are the effects of the antidote on the fetus? And a lot of times you have to say, well, if the mom doesn't make it, the fetus isn't going to make it, right? So oftentimes you have to kind of forego some of those concerns and make sure you take care of the mom first. So this is probably actually a good thing that more antidepressant use is happening, but we also don't know the long-term ramifications of that. So we'll talk about that a little more. Okay, so the main thing we're going to be talking about is going to be teratogenesis when we're talking about drug use during pregnancy. These are going to be any kind of significant postnatal change in function or form of the offspring after prenatal treatment, right? So certainly there can be some congenital anomalies that are occurring, but specifically when drugs are being used, we're talking about teratogenesis and those effects they have on the fetus. So some good examples of known teratogens. These are drugs that are very good to avoid in pregnant patients because we know they're going to be causing some major issues. And so this is not an all-inclusive list, but this is definitely a lot of kind of high priority drugs you should avoid in your patients. So certainly ACE inhibitors. Anything that will be affecting angiotensin can be affecting the fetus pretty significantly. Of course, that's going to be affecting things like blood vessel development, things like that. This will also go with the ARBs, or the angiotensin receptor blockers, that can affect the fetus as well. Anything that are affecting hormones, so certainly if you have androgenic drugs, can be affecting the fetus. Cigarette smoking, cocaine. We will see that hypercoagulability is a concern in pregnant patients, so things like Warfarin, which is a pretty common anticoagulant, should not be used in pregnant patients. We'll talk about some other drugs that would be safe to use in them. And then you also have things like isotretinoin or Accutane. You guys remember what we use that for? All right. You guys remember the precautions we put in place to prevent exposure to pregnant patients with Accutane? Yeah, iPledge system, right? So that's a REMS system. That's something the FDA mandated that the drug manufacturer put in place. It's called a risk evaluation and mitigation strategy. And essentially it's making sure that pregnant patients are having pregnancy tests done, making sure that the prescribers, the patients, and the pharmacies are registered with the iPledge so they make sure they know who's being prescribed the drug and who's getting it. So that way they try to minimize the number of fetuses who are being affected by this drug. It's going to have very, very dramatic effects on the fetus. Other ones, and these can be very difficult to treat patients with history of epilepsy. So things like phenytoin, valproic acid are frequently used in those patients, so that can provide some problems there. Lithium can be another one. You guys remember where we use lithium at? Or does anyone know we're going to talk about that a little bit later in the semester? Yeah, bipolar disorder. So that can be a problem because if you have a bipolar patient who all of a sudden has to come off their meds because they're pregnant, that can lead to relapse of symptoms, and that could be potentially problematic for them. Then thalidomide we mentioned. Does anyone know where you might use thalidomide nowadays? Because we actually do use it in the U.S. Cancer? Yeah, cancer is the only place you might use it. I think it's for very specific cancers. I'm not sure off the top of my head, but that is one place where you may see thalidomide being used. So again, not all inclusive. You'll see that certain drugs are all going to have caveats. We'll see things that will have different effects during different trimesters depending on how they're affecting the fetus specifically. We'll talk more about that. So how do we determine the teratogenicity of a drug? Do you think we do randomized controlled trials in pregnant patients? Probably not, right? Because there's kind of some big ethics concerns there. You don't want to do that. You don't want to say, okay, here, let's impregnate a bunch of women, give half of them this drug, half of them no drug, and see what happens. They might get mad at that. So we have to use a lot of observational kind of retrospective reviews of things, right? So we look at things like case reports. So you look at things like, okay, the mother was exposed to these different drugs. This is the outcome that happened. How much association or how much causality can you address or can you associate with those case reports? Not a ton, right? Because if you have just an N of 1, it's hard to say that this is truly causal. A lot of times you have to look at larger numbers of things. So you can look like at case control studies, you can look at cohort studies. We talked about that a lot in EpiBio, which you guys have probably forgotten all about, right? Hopefully not. But so use a lot of those studies, which again are not going to be experimental studies, they're more just observational studies to look to see, these women have these outcomes, let's see what kind of risk factors they had. Or these women who have these risk factors, what type of outcomes are they going to have? Depending on how you're going to look at that. And there's also voluntary reporting systems. So a lot of times for medications, especially ones that we know to have potentially high risk effects on the fetus, we have reporting systems available. So imagine, if you were a mother who had epilepsy, you were taking something like valproic acid, and then you became pregnant. You didn't realize that you had, say, a month period where you were, say, the baby was being exposed to that. That's something where you could report out to these monitoring systems and say, hey, I've been exposed for this amount of time, this is the dose I was taking, blah, blah, blah. And then whatever happens with the fetus, like they get that report and then can start to look back and see like, okay, well, this is the effect it had when you took this dose for this long. Maybe they can compare it to some other mothers who may take it longer or shorter or whatever happens to be. So we use all of that information to help us to determine what the teratogenicity of the drug actually is. So we not only use human information, but we can also use animal studies. But what are some of the limitations with animal studies?
Not human.
They're not human, absolutely. All right.
And
So
they can't physically report like pain or
Sure, yeah, so there may be some things you can't necessarily get, so the mouse isn't going to go, pain scale of out of 10 or something. They can't really do that. But what we can do is at least extrapolate some information. So certainly there will be drugs that will have negative effects, say, in mice and their fetus, but maybe have no effect in humans, right? We may be able to determine that, especially with older drugs and some of these epidemiologic studies. A lot of times if you see negative effects in the animals, that could be extrapolated to humans. It just really depends. And so a lot of times you can't take full credence in animal study information, but some of it could be extrapolated. But just don't put total stock in that. Of course, the actual disclaimer is always going to be safe use of this drug in pregnancy has not been established. Should only be used when anticipated benefits outweigh the risk. And so again, you're always playing a risk-benefit game when dealing with these pregnant patients because we really don't know. You could have a 1 in a million chance of having some negative effect that we don't really know about, right? Because again, these are not well-studied drugs in this population. So again, always try to use as few drugs as possible for these particular patients. So the different stages of fetal development, obviously, there's kind of the pre-implantation stage that happens very early during post-conception, and then there's this stage called organogenesis, which is the majority of kind of the first trimester. You can see here, this is kind of the most important stage where a lot of the organs are being developed, and this is where most of your medications can have negative effects. And again, how many of your pregnant patients are going to actually know they're pregnant during this time frame? Who knows, right? So a lot of them may not actually know for some period of time during this first trimester where they could be having kind of unknown drug exposure. And then you'll have the rest of the fetal period. This is where you'll have really functional maturation of a lot of the organs. You can still have negative effects from medications. It just may not be as critical as you would see if you'd been exposed during that initial organogenesis. Now, certainly chronic use of certain drugs, things like especially opioids, cocaine, things like that can certainly have long-lasting effects on the fetus, especially after they're born. We'll talk about that a little bit later. So again, looking at different drug effects on the developing fetus, some of the factors we'll look at. So looking at the stage of pregnancy during exposure. And so we mentioned NSAIDs. We saw that ibuprofen is probably the most common one used as an over-the-counter medication. And so, early on in pregnancy, this is probably an okay medication to use. But we'll see that in later stages, we'll see the actual pregnancy category of the drug will change over to a D. And we'll talk about what those different categories are in a little bit. But NSAIDs basically can lead to kind of early closure of the ductus arteriosus in the fetus. You can actually end up having closure of that kind of that two-way valve for blood to flow within the fetus kind of early, and it can lead to some issues. So this is one of those ones where early on in pregnancy may be okay to use, later on may not be. So you need to look at the specific drugs and see where the problems lie. And oftentimes it's hard just to look at a letter to say what the actual risk is going to be. We'll also see route of administration is going to be important. So when do you think route of administration might be affecting exposure?
Like morning sickness, they can't keep something.
Okay, yeah, so if they couldn't keep something down, like if they take something orally. But also think about if the more locally you can use a drug for its effects, the better off you're going to be. So imagine corticosteroids for asthma, right? We oftentimes use inhaled corticosteroids because that limits the amount of systemic drug exposure you're going to have, right? Instead of taking prednisone every day to control asthma, we're going to take something like fluticasone that you can inhale and control those symptoms. That would also limit the amount of drug exposure that the fetus would be getting exposed to, right? So if you can use things more locally, topically, sometimes that can help as well. That's going to help to limit the amount of exposure that the fetus might actually be get exposed to. We'll also look at the dose. The duration can also be affecting this. So again, the longer a patient is taking a medication, the more drug is going to be exposed to the fetus. The dose, higher the dose, and the more the patient's going to get, right? Because basically all the blood flow going to the mother is going to eventually make it its way to the fetus. And so we'll look at some issues with placental drug transfer, how that can affect the fetus. But again, a lot of the drug exposure the mother's getting is going to happen to the fetus. So we know drug effects can range anywhere from, say, no effects whatsoever, but we can also see very deleterious effects, whether either actual destruction of the fetus, structural anomalies, growth retardations, all these things can occur, and it could be a spectrum, right? A lot of it could be due to dose or duration of use or when during the pregnancy the actual exposure happened. So what are some of the things that affect placental transfer of drugs? And so a lot of this is going to go back to when we talked about, say, transdermal absorption of drugs, right? It goes back to the physiochemical properties of the drug itself. And so one of the things we'll look at is that the placenta is really meant to be a protective barrier. And so based on the physiochemical properties of the drug, it may not be very easy to penetrate the placenta. Some drugs may have a much more easy time penetrating that. And this can go along when you're talking about things like blood-brain barrier transfer as well. Very similar properties here. So lipid solubility. Do you think things cross easier if they are more lipid soluble or less lipid soluble? Probably more, right? So the more lipid soluble a drug is, the easier it's going to be able to cross that biological membrane. Again, very similar to the blood-brain barrier as we've seen previously. We can also see charge of the molecule is important as well. So remember that things that have a charge or do not have a charge, which one of those cross easier? There's a no charge, right? Because you don't want them to have, you want them to be more fat soluble, so losing that charge is going to make them easier to cross that membrane. And so you can actually have issues of ion trapping. So especially if you were to have, say, changes in pH between, say, the amniotic fluid versus the mother's plasma, that can actually end up leading to where a drug may be uncharged in the plasma, crosses the placenta, and now it goes to a different pH where it actually has a higher proportion of it being charged, and the drug will actually stay there for longer. So you can have some issues with that. You'll see that same thing happening with breast milk as well. And then you want to look at things like molecular weight of the drug itself. We're measuring these oftentimes in Daltons, so that smaller molecules, things that are, say, between 250 to 500 Daltons will be able to cross very easily, whereas larger molecules, very large things like, if you think about drugs like vancomycin, have a very, very large structure. Those have a hard time crossing those biological membranes, right? Don't memorize these numbers. Just realize that smaller molecules get across easier rather than larger molecules. And then how do you think protein binding is going to affect this? Yeah, absolutely. So the higher proportion of the drug that's being bound by serum proteins, the less of it that's free to cross the placenta. So if something is, say, 95% protein bound, is going to have only 5% of that drug active to cross the placenta versus something, say, it's only 50% protein bound. You have 50% of that drug that's free that could cross over, right? Because those proteins aren't going to be transferred over to the placenta, so they're going to stay in the mom's serum. So as long as they're holding on to the drug, that drug can't cross over. So things with low protein binding are going to have an easier time crossing over. You will also see that this actually holds true for when we talk about things like removal of drugs by dialysis. These same principles hold up. So anytime you're trying to get drugs across a membrane, these same principles hold up. So these are good kind of ideas to hold on to. Okay, and so we'll see that as far as metabolism of drug goes, there's two main mechanisms that help to protect the fetus from drugs in the maternal circulation. So we have the placental function, being some kind of semi-permeable barrier, as we've kind of mentioned already. There is some limited drug metabolism that you'll see happening in the placenta. There's some enzymes and things like that that can help break down some of these drugs. And then you'll also see that a lot of the drug that enters the fetus is going to be happening through this umbilical vein. And so we see that 40 to 60% of umbilical blood flow actually enters into the fetal liver. So how well developed do you think the fetal liver is? Not great. And we'll talk about in the ped section, we'll talk about how immature their liver is, and we'll talk about how their enzymes kind of ramp up after birth. So it's not going to be nearly as good at metabolizing drugs as an adult liver would be, but you can still get some degradation of drug happening there. But even though we have these protective mechanisms in place, you're still going to see that whatever the mom's being exposed to, at least some of it will be getting crossing over to dealing with the fetus. Okay, so have we covered pregnancy categories before? Okay, so we'll just mention them briefly here. So again, what would a category A drug be considered? How would you describe that to a patient?
Very little risk.
Very little risk, no harm, right? And so if you talk about the actual data behind how you come up with that A category, you would say that we have controlled studies in women who have failed to demonstrate risk during the first trimester, and we don't really have any fetal harm to speak of, right? Again, we're talking in biostats terms, right? We're never going to be 100% certain on anything, but it appears there would be no harm done by this drug, right? Very little risk associated with this. So those are the easiest ones. How many drugs do you think fall into the A category?
Few.
Very few, right? So things like very old drugs that have a lot of kind of historical data to back up their use would be included in this. A lot of vitamins and things like that. So something like folic acid certainly would fall into a category A drug because we know that's just something natural that the body needs. So of course that would be a category A drug. When we get down into B, how would you describe B without reading off the slide?
You'd probably still give it to them.
You would probably still give it to them? If your patient goes like, what does that B mean though? So how you could describe it would be that, okay, well either we have no animal studies and then no human studies that show that there would be risk to the fetus, or even if we have animal studies that have shown risk, we have enough human data to show that the risk is very, very low, right? So I would definitely feel no problem giving a category B drug to a pregnant patient based on the available data, right? So we can say, yeah, these are very, very safe to use. May not be quite as ironclad as an A drug would be, but B is still pretty easy to use. And again, we've had no human data to show that there could be risk. Okay, how many drugs do you think fall in this category? A few, probably a little bit more than category A, but still not very many, right? Where do you think the lion's share of drugs fall into? C, right? So we talked about C not being a super useful tool when trying to analyze whether a drug is safe to use in a pregnant patient. So C is going to be that the animal studies may indicate risk, and have no adequate controlled human studies. Here again, we're using kind of a risk versus benefit. So could be that we just have animal studies that may indicate risk, but we have no human data that shows us this, but we don't really have the breadth of data that you would see with like a category B drug. Or animal studies don't really show anything, but we don't have enough data in humans to say that yes, this is okay. So again, this is kind of just a kind of your kitchen or your kitchen drawer, kind of where you shove all like the old electronics and batteries and stuff you don't use anymore. This is where all the other drugs fall into for the most part. So C category. And again, not super useful if you're trying to determine whether I should give this drug to my patient or not. Because again, you may not know, that 1 in a million side effect that could occur that could affect the fetus. And then your other two are going to be D and X. D would be that we do have positive evidence that there could be fetal risk. And here you're really making more of a risk versus benefit analysis. So you're saying that, okay, what are the benefits to the mom? And what are the potential risks to the fetus? How can I balance those out and whether or not I should use this medication, right? And so very few drugs fall into this one, but it could be drugs that we know have deleterious effects. This may be based on the trimester, but again, you don't get a ton of information. Even if you saw a drug with category D, you probably wouldn't use it in your pregnant patients, but there could be circumstances where you would want to use it. You need more information before you can kind of make that determination. And then finally, category X really should never be used, right? So we have positive, negative effects in the fetus. Really should never be. There's no point where the benefits outweigh the risk. Accutane falls into a good category of X. Yes.
As far as the whole Warfarin controversy and pregnant, which one would that fall into, C or D?
I actually have that as an example just a little bit. It's actually category B.
Oh, it's a D.
Yeah.
I know they were making a huge thing on the TV about it.
Yeah, like you know,
What's going
you
on?
received it while you're pregnant. Call me and I'll get money for you. No, Zofran's used very, very frequently in pregnant patients. But we'll talk about dealing with pregnancy-associated nausea, vomiting just a little bit. I'll show you some examples of the information out there. So. When we're talking about transfer of drugs over to the breast milk, we'll see that very similar effects are happening, or very similar factors of the drug are affecting the transfer over into the breast milk. So again, things that have a high lipid solubility are going to have an easier time crossing over into the breast milk. You can also see ion trapping happening there as well, because the breast milk is going to be, say, like a little bit more basic than, or maybe. Or more basic or acidic, but sometimes drugs can get trapped over there, and it will be on a drug-by-drug basis. And again, molecular size and protein binding are going to have the same effects here as you would see with the placenta. So just keep that in mind, that these are going to be things that are affecting transfer of drug from the maternal serum over into the breast milk. So we'll also see that time since delivery can be affecting this as well. Early on, after the baby's born, say the first 2 weeks postpartum, you have larger gaps in the alveolar cells and the mammary glands, and so this can actually lead to higher drug transfer early on. So that can be affecting it. And so you'll see that the major determinant of the maternal serum concentration, the higher your concentration in the blood in the mom, the higher the concentration is going to be in the milk. So we can talk about this strategic scheduled feeding. So have you guys heard of pump and dump? Oftentimes, if mom's probably gone 9 months without any alcohol, she probably would like to maybe have a glass of wine, especially with a new baby screaming. So you can sometimes do kind of these strategic feedings where you can basically feed the baby, and then your mom could have the exposure to the drug, whatever it happens to be, over a long period of time where you may not need to feed for a while. Or say you would have the drug exposure, mom would then take that breast milk, extract it, dispose of it, and then any new milk there would have lower concentrations of the drug. So again, looking at that, you can have different kind of strategic time frames to try to make sure you have as limited exposure to the fetus as possible.
On drug labeling, does it indicate like how long after taking that drug you can breastfeed?
They will have information. Yeah, they usually have guidance on, saying, and again, you can look at the half-life of the drug, and it'll kind of tell you how long that drug's gonna be sticking around for. So for some drugs that are working for 24 hours or longer, you're always gonna have some degree of it. So if you think about something like fluoxetine or Prozac, it's frequently prescribed for postpartum depression. That's a very, very long half-life, has active metabolites that stick around for a while. So you really can't ever have a period where the baby might not be exposed to any of that drug, right? So, but for things with shorter half-lives like alcohol, you can certainly try to schedule those things out a little bit easier. And so looking at the pH of the breast milk here, you can see it is a little bit lower. So again, things that are going to be more basic drugs, as they cross over into the breast milk, they would end up being trapped because they become ionized as they get down to these lower pHs, and then can have a harder time crossing back over. So they have done a better job in changing the pregnancy labels that come along with the drug inserts, or the information that comes along with a lot of these prescription medications. So again, with the A, B, C, D, and X, there was very limited information you could actually pull from that. It's very difficult to determine really what the safest thing to do for your patient, or the best, what was in your patient's best interest. So nowadays they've updated it so that labeling is a little bit easier. So the current labeling, what was done in the olden days, you would have pregnancy, labor and delivery information, then nursing mothers, right? So that would kind of cover your three different issues. Now they've actually kind of condensed some of this to where they put the pregnancy, labor and delivery issues all into one. So just say, here's all your pregnancy information. Here's what we've seen in clinical trials. Here's what we've seen in post-marketing data based on if the drug has been out for some period of time. You'll then have a lactation section, and then you'll also have one with reproductive issues that could come up, right? So something like Accutane having negative effects if a male who was on it got a female pregnant, right? You can have some drug transfer there. So those are all things that would be added into that new section for reproductive potential for males and females, right? So that's the new labeling you'll see if you're to look at the drug inserts going forward. So it's a little bit more useful. Here's an example of, I know this is hard to read, but you guys can blow this up on your slides. But for example, if you look at a drug like Warfarin, right? You guys remember how Warfarin works?
Vitamin K antagonist.
Yeah, so it's a vitamin K antagonist. So again, anytime you're you're kind of mucking around with vitamins in the baby, especially fat-soluble vitamins, you run into some big problems. So Accutane messes with vitamin A, you see Warfarin messing with vitamin K. So these can all have very negative effects. And so you'll see here it's a pregnancy risk factor D. So that means that there could be some situations where warfarin may be beneficial to the mom that might outweigh the negative effects on the fetus. But again, that doesn't tell me when that situation is. So the nice thing is that you can, and this is from LexiComp. It's a very common drug information resource. On whatever hospital you go to, they'll have a particular reference for their hospital, and so our hospitals use LexiComp, so that's just what I use. But anyway, so you can see much more specific information here. If you look at the pregnancy considerations, you can see, okay, here it crosses the placenta. You'll see that concentrations in the fetal plasma are similar to maternal values, so you can see that warfarin crosses very easily, and then you can actually go down and see specifically what type of negative effects would happen to the fetus. So you can try to gather more information to say, okay, when are the situations where I should use this drug versus when I shouldn't? And then you also have some information here on breastfeeding considerations. So you're seeing a lot more information being put into these drug references to make you a little bit more informed when you make these decisions, right? An example of Ondansetron or Zofran, which is frequently used for pregnancy-related nausea vomiting. Here you can see it's a pregnancy risk factor B, so at least we have enough information to say that yes, there's probably no harm for fetuses, for mothers who are taking this. And you notice here they'll actually tell you, okay, there's no teratogenic effects that were observed in animal reproductive studies. We see that even though it does cross the placenta during the first trimester, it can be detected in fetal tissues, there's really no negative effects we found here. So again, this information's out there. Just make sure you're referencing this prior to prescribing a new drug for your pregnant patients. Just memorize all this and it'll be on the test. Just kidding. Just kidding. Okay, so now we're going to focus a little bit more on the mom specifically. We're going to talk about some of the maternal changes that can occur during pregnancy, and we'll talk about the complications of that and the medications we can use to help treat those patients. Some of the drugs we're going to talk about today are going to come up in future lectures, so just be aware of that, especially like the GI drugs. We're going to talk about that in a couple of lectures. So what happens to the mom during pregnancy? So changes are going to begin during the first trimester and really start to peak during the second. And so we see that blood volume is going to go up pretty significantly by 30 to 40%. We see that renal blood flow is going to go up. Their GFR increases pretty significantly there, and also cardiac output is going to go up. Usually you can see that the blood pressure should remain somewhat constant, but heart rate may go up in order to help keep up with this added blood volume to make sure things are kind of pumping appropriately. So basically just a lot of extra volume. Very interesting to see this, from a recently pregnant wife to going from kind of pre to post to just how much water she wanted to intake because she got very, very thirsty because she wanted to keep up with that increase in blood volume, right? And then after the pregnancy, how much she diuresed a lot of that off because she didn't really need that much blood volume anymore. She didn't have to support that extra person inside of her. So you'll also see that things like GI motility will decrease, which can be affecting a lot of their GI woes that pop up, like nausea, vomiting, can affect things like constipation that can occur. They're also going to be in a hypercoagulable state. If you imagine this blood volume going up, there is some degree of kind of sludging that happens because their hematocrit's going up, their hemoglobin's going up, but you can see some kind of stasis that can occur because, again, sometimes, especially, you don't have a ton of energy, you don't want to be moving around a lot. You can have sludging of the blood that can lead to this hypercoagulable state where they're more likely to have a clot, right? So that can be a big issue. You'll also see that they have decreased albumin stores, which will mean that highly protein-bound drugs are going to have a higher volume of distribution. And that makes sense because less of it is being bound up by albumin in the central circulation, meaning a higher percentage of it can go out to the tissues and increases VD. And then you also see the weight gain here, which will affect fat-soluble drugs as well, will increase their volume of distribution because they have a higher percentage of adipose tissue at that point. So how do you select drugs in pregnancy? Obviously you want to avoid them whenever possible, but that's not always going to be the case. You may need to think about treating both acute and chronic conditions. So if mom has depression before the baby comes along, she's still going to have depression during the pregnancy, right? So you need to consider, what are the risks for the mom going off the medication versus the risk for the fetus from the mom staying on the medications, right? And so a lot of the goals here are to identify medication use prior to conception if possible, try to eliminate any non-essential medications, and then try to discourage self-medication. So really make sure you're having a dialogue with your patients that, if you need to take something, if you're having problems, let us know so that way we can discuss and come up with the best drug for your situation. And then if we can, minimize the exposure to known harmful medications, either by decreasing the dose, changing the route of exposure, or maybe using a different dosage form, which will help to limit exposure to the fetus. So those are kind of our goals here when we're selecting drugs for our pregnant patients. So here are some of the conditions we're going to talk about specifically in how we can treat this for our pregnant patients. We'll look at some drugs to avoid, and we'll also look at the drugs that are going to be most recommended based on their pregnancy categories, based on their safety profiles, and based on the other side effects that they can cause for your pregnant patients. So first off, nausea and vomiting. It's going to be very, very significant for a lot of your patients. Especially during the first trimester, we can see this pretty significantly. It's actually kind of an interesting story. So my wife's sister is just recently pregnant. So she's in her first trimester currently, and very similar to my wife, had terrible nausea, vomiting, right? Just feeling the worst. Interestingly enough, her husband is from Ecuador, where his dad is a OB-GYN physician. And so he said, okay, you guys are having all these problems. So they ended up coming up from Ecuador and actually brought some Ecuadorian medication with them. And so we're giving it to her sister, and of course my wife being a pharmacist was like, what the heck what's he giving you? What's this crazy non-FDA approved medication? And it actually included things like chlorpromazine, which is an antipsychotic that we'll talk about a little bit later. It included some hyoscyamine or an antispasmodic medication. But we basically were like, maybe you shouldn't take these medications. Let's maybe go with what the guidelines actually show to be safe and approved. But just be aware that patients from different ethnic backgrounds are going to have different beliefs and may have different medications that they're using based on what their grandma told them to take, or what their physician who's over in Lithuania said, oh, this is good to use, right? So just be aware of that. Obviously, if we can do dietary changes, that's going to be best. So smaller, more frequent meals, maybe avoiding spicy foods, things like that. But the most effective medications that you should use are going to include, easy enough, vitamin B6 or pyridoxine, and then also doxylamine. Does anyone know where you might find doxylamine in the over-the-counter section?
Is it Dramamine?
It's not Dramamine, close. Unisom. So you'll oftentimes see this being used as an over-the-counter sleep aid. It's a first-generation antihistamine, so it's very similar to Dramamine or things like meclizine or diphenhydramine. Very similar to those drugs, but these are both useful, and actually we recommend use these in combination. So oftentimes what I recommend to patients or friends or whoever, just go to the store and just buy a bottle of pyridoxine and buy a bottle of doxylamine. It's a lot cheaper than what you would actually get with the prescription product, which is just recently put on the market. It's a product called Diclegis, which is a combination product. It is delayed release, so it has a little bit longer duration of action. So you may not need to take the medication as frequently, but it also costs a heck of a lot more money. Right? So if cost is a consideration for your patients, I just tell them to buy the two products separately and just take them together. Right? This works very, very well for a lot of patients. I usually recommend they'll take the first dose at nighttime, because this again will knock them out, so it gives them time to kind of get used to that antihistamine effect. It may make them a little bit more groggy, may sleep a little bit more, but that might be okay for them, depending on the situation. Other drugs you can potentially use, and again, even though my sister-in-law's father-in-law, I guess, had recommended a drug that can contain chlorpromazine, which is an antipsychotic, it's actually chemically related to a drug called promethazine or Phenergan. You guys heard of Phenergan before? Mm-hmm. Yeah, so Phenergan is another drug that is in the class of phenothiazines, which includes a lot of the first-generation antipsychotics. There's actually some interesting history behind how we got a lot of those drugs. But anywho, it has antihistamine actions. It has some antimuscarinic actions, both of which are going to be useful for helping to decrease that nausea, vomiting sensation you have, especially in that chemoreceptor trigger zone. We'll talk more about these in the GI section, but just be aware that we're using them here now. Also have metoclopramide, otherwise known as Reglan. And these are also going to be useful because they actually help to block dopamine receptors, D2 receptors specifically in the CNS. And that also helps to have antiemetic actions. So again, if you have patients who are failing things like pyridoxine or doxylamine together, then you can consider using one of these other drugs, right? So those are used for a long time. These are old medications, the promethazine and metoclopramide. Nowadays we have the 5-HT3 receptor antagonist. You guys remember what 5-HT is? Yeah, serotonin, right? So 5-HT is serotonin, just the chemical name for it, 5-hydroxytryptamine. Essentially, we have a lot of different serotonin receptors, and we had the 5-HT3 receptor specifically that when being activated help to induce nausea and vomiting. So we'll have antagonists that will actually sit on that receptor and prevent their activation. So this is where you have your Zofran, Ondansetron. You'll have also other drugs used less frequently, but Granisetron and Dolasetron. These are all going to be category B as well. So these are safe to use, but again, they are frequently going to be more expensive, and they also require a prescription. So to keep that in mind, that's usually kind of a backup drug to use if they are failing kind of the over-the-counter modalities. The metoclopramide and promethazine will also be prescription-based products as well. So again, they can get the diclegis with the prescription, but just the pyridoxine doxamine they can buy over the counter, no problem. Promethazine is also nice because it comes in a suppository form as well. So in case they cannot tolerate anything orally, you can also use a suppository to help kind of control that. So we don't have a ton of data on lactation for the 5-HT3 antagonist, but usually by then a lot of the nausea vomiting has kind of subsided after the birth. But again, we'll talk more about these agents in detail when we get to the GI section in just a little bit. Okay. Then moving on, heartburn can be another big problem you'll see with some of these pregnant patients. So again, eating more frequent, smaller meals can help to eliminate this. And here you want to use medications with as little systemic effect as possible. But you'll see that the majority of these drugs are going to be pretty safe for the most part. Again, we'll talk about these more in the GI section, but we'll just have a brief overview here. So we can use antacids in moderation. So can anyone think of any antacids you might use? Tums, which is what? Calcium carbonate. Yeah, calcium carbonate is a good one. Think of any other ones? Gaviscon's not really an antacid specific. We'll talk about that. Sodium alginate. So you can have like sodium bicarbonate can even be one. So sometimes you'll see sodium bicarbonate being used. Magnesium hydroxide. Usually you'll see magnesium hydroxide and aluminum hydroxide mixed together from Malox or Mylanta. So you'll see a lot of these antacids being used, and those just help to neutralize the acid within the stomach, right? So when you do have that reflux, it's less acidic, it's less painful for the patient. You'll notice here that we will frequently avoid giving sodium bicarbonate because of the effects it can have on the blood pressure. Because again, if they're taking in more sodium, they're holding on to more water, which can affect their blood pressure. And we'll talk about preeclampsia and all of that in a little bit, but if you can do anything to help that, you want to avoid that. And also magnesium trisilicate is not really found to be super useful. Magnesium hydroxide is usually pretty safe though. We'll have another drug called sucralfate or carafate. This is a drug that's good for coating the stomach and helping to neutralize some of the acid. Just helps to provide a better barrier against a lot of the acid that the stomach is producing. Again, very safe because these drugs are not being absorbed systemically for the most part, right? You can use H2 antagonists. These would be things like ranitidine or famotidine. Those are pretty safe for the most part. They're older drugs. A lot of them are available over the counter, so they're easy to acquire. Those can be used very safely. And if those are failing, then you can utilize, step up and use your proton pump inhibitors. So these would include things like your omeprazole or esomeprazole, things like Prilosec and things like that. So we'll talk about those more in the GI section, but just know here that again, most of them are safe, but usually you kind of want to use a stepwise approach. So start with the antacids. If that's not really working, you kind of bump it up to your H2 antagonist, and if that's not working, still PPIs, because those are newer agents and usually have less data associated with them. Okay, going to constipation. So obviously the easiest thing to do for these guys is to do their dietary modifications so they can increase their fiber intake and increase water intake. This is also going to help to provide some better bulk for the stool and going to help pass things along. Even some moderate exercise can kind of help get things moving because again, very frequently they are very tired. They do not want to move around just due to the fact that they have a huge basically parasite on them. Just encourage them to get up, walk around, even do a little walk every single day can help out a little bit to help kind of relieve some of that. Now, again, here when we're using medications, we want to use things that are not systemically absorbed whenever possible because it's going to lead to less systemic exposure to the fetus. So bulk-forming laxatives are going to be recommended most frequently, again, because they're not being absorbed. So these are helping to kind of increase the bulk in the stool, helps to draw water in, can help pass things along. So these would include things like your methylcellulose, your psyllium husk, like your metamucils, and things like that. Those are all very useful. You can also use surfactants or stool softeners. So Docusate is going to be the big one there. Just basically helps to kind of lubricate the stool to help it pass a little bit easier. Does anyone know where you might use Docusate anywhere else in the body? A little bit of trivia. So you can actually use Docusate in the ear. It actually helps with impacted cerumen. Actually can help break that up. So sometimes you'll see that being used in the ear. Just know that's pretty well used, especially in kids and stuff like that. It helps very frequently. And then you can also use osmotic laxatives. These again are just helping to draw a lot of water into the colon to help signal that urge to defecate. So this is where you're going to find your polyethylene glycol or your Miralax. And again, frequently this is being used very commonly. Again, because it went over the counter, it's very readily acquired. So it's used very frequently. And then usually you want to avoid stimulants whenever you can. So things like Senna, your bisacodals, because they can patients can become reliant on stimulant laxatives over a period of time. They directly stimulate the colon, the GI tract to help increase peristalsis. Over time, if you use them chronically, you're going to see that the patient needs that stimulation, that external stimulation, because they've not really had to do it themselves. So you can lead to some issues there. So again, use them sparingly. And then you also, mineral oil is sometimes used as a laxative as well, but this can actually decrease absorption of fat-soluble vitamins. That's usually not recommended too frequently. So again, bulk-forming laxatives, polyethylene glycol, those are going to be your go-to drugs. With Docusate you can use as well. All right, so I'll give you guys a 10-minute break now, and then we'll come back and finish up the pregnancy section. All right, any questions on the first half? There's only 28 slides in. I have like 100 something the next 2 days, so I'm gonna get going. All right, so hemorrhoids will be the next thing we'll talk about as a common complication for pregnant women. The best thing to avoid this is to just avoid constipation. So if you can kind of treat that early, avoid straining, unnecessary straining, you can help to avoid the hemorrhoids. So again, here we're going to be using external products because they're going to help with limited systemic absorption. And so you'll see that really as externally applied as possible. Any kind of internally used product are going to have more systemic absorption. So oftentimes you're going to see drugs like Preparation H being used. A through G were no good, so we had to use Preparation H. Just kidding. And those are typically going to include things like hydrocortisone, which kind of works as an anti-inflammatory. Thank you. Glad someone got the reference. And then also phenylephrine can be used here as well. Why do you think phenylephrine is good to use?
Mucosal tissue, isn't it?
Yeah, so what is a hemorrhoid?
Blood vessels.
Yeah, it basically is a bulbous vein that's sticking out. So if you can use something that can help to have vasoconstrictive properties to help clamp down on that, like phenylephrine, that helps to constrict that somewhat and can help shrink it down. Again, it's inflamed, so that's why you use the hydrocortisone as an anti-inflammatory there. You can also use Tux. Tux are frequently used for hemorrhoids, and that includes a product called witch hazel, which is basically just an astringent, which helps to kind of squeeze down on that kind of the epithelial cells and will help shrink that as well. So those are the commonly used products. Again, using more external products like creams and things like that rather than using the suppositories, because again, those will have a little bit more systemic absorption. And then you can also use Sitspast as well, that will help to kind of ease some of the pain and the inflammation there. So, and then diarrhea, we will use bulk forming laxatives here. So that's where you get your methylcellulose, your psyllium husk. Those can help to kind of give a little bit more form to the stools and help to limit some of the diarrhea. And then we'll also talk about a drug in the GI section called loperamide. This is actually a drug that works on the opioid receptors. Actually, we'll see with opioids, they slow down the GI tract when you agonize those receptors. And so with loperamide, it actually doesn't cross the blood-brain barrier. And so that's why you don't really get analgesia or euphoria from the drug, but it works directly on the GI opioid receptors to help slow down peristalsis, so it can help to limit some of that diarrhea. So that's a very common one you'll see being used as an over-the-counter product. So next we'll talk about the pregnancy-induced hypertension. So again, this can be, we'll see that there is chronic hypertension, which will be either pre-existing or it develops prior to 20 weeks of gestation. You can have gestational hypertension, which is here is defined as BP over 140 over 90, in the absence of proteinuria. So again, you're not necessarily having such high pressures that you're actually shedding proteins in the urine here. And then we'll talk about mild preeclampsia, which is where you're going to have hypertension accompanied by the proteinuria. And you can see this can be somewhat common, affecting around 6 to 8% of pregnancies out there. So it's something definitely we want to keep on your radar when monitoring your pregnant patients. So you can also have more severe forms, so you can have severe preeclampsia, and then actually eclampsia itself, which is these kind of generalized tonic-clonic seizures that are occurring in patients with pregnancy-induced hypertension. So we'll see some of the medications that we can use to treat both pregnancy-associated hypertension and also eclampsia. So as far as non-drug management goes, activity restriction can be used, although this could lead to increased risk of venous thromboembolism. So again, too much bed rest is not necessarily good for your patients for other reasons as well, but that may help with the blood pressure. Try to do some stress reduction, maybe some mild exercise can all help to limit some of that blood pressure effects. We can see that calcium 1 to 2 grams daily can actually been seen to decrease the relative risk of hypertension by around 30%, and also preeclampsia by about 48%. So this could be another supplement that your patient may be taking. Hopefully they're taking their prenatal vitamins anyway, but may need some additional calcium on top of that. What's a potential problem with giving calcium to one of these pregnant patients? Yeah, constipation can be another problem. So again, this could be another complication you can see from that. So kind of keep that in mind. If your patient's already having problems with this, maybe it might not be the best drug for them. And then you'll also see that magnesium sulfate is going to be used to decrease the risk of progression from preeclampsia to eclampsia by about 60%. So this is something they'd be using, say, in the hospital. They can also be used to treat eclamptic seizures as well. Magnesium is good because it acts as a smooth muscle relaxant. So it actually kind of works very similar to a calcium channel blocker, and how it helps relax that vascular smooth muscle. It can help decrease the blood pressure. It's kind of interesting because in a lot of places, when you're giving magnesium, they're very concerned about the hypotensive effects. You get flushing and things like that. They kind of limit how fast you can give it, but you'll never see anyone give so much magnesium as you do in the OB wards, because they will give 4 to 6 grams IV over 20 minutes and just give 2 grams an hour as a continuous infusion. Usually if we're doing like, say, 2 grams in a patient, we have to run it over an hour and give them a fluid bolus beforehand and be very, very ginger with it, whereas these guys will just slam it in them, give them some fluids, and you should be good, right? Because they are already so hypertensive as it is. We'll see that drugs like benzodiazepines and phenytoin, which are frequently used for seizures, should not be used. We'll see that these drugs are going to be bad for fetuses. They are teratogenic, and we'll talk more about those in the neurology section. So really, magnesium is going to be your drug of choice here. Does anyone know what else you might use magnesium as your drug of choice for?
Headaches or migraines?
Potentially for migraines, but how about like a potentially life-threatening arrhythmia? Yeah, torsades is going to be your other place where magnesium is a lifesaver. Okay, so as far as chronic management of hypertension, we already mentioned that we can't use our ACE inhibitors and our ARBs because those are known significant teratogens. So what we can use on the other hand would be something like labetalol, which is what type of drug? Without looking at the slide. Beta blocker, absolutely. So it's a third generation beta blocker. It's nice because it also has some alpha blocking properties as well. So it can help to decrease blood pressure not only by affecting the heart, but it can also affect some of those alpha receptors peripherally as well. In a lot of places you'll see this being used more as a first line agent. You can either use it orally for kind of chronic management, and it's also nice because it has an IV form available. So if you had a patient who's in the hospital side, you can give them boluses for acute management of hypertension. So it's a good drug to go to for that. Methyl-dopa is a drug that used to be the drug of choice. It's probably still out there, just depending on the provider who it is. But this is an older drug that actually works by stimulating alpha-2 receptors. It kind of works very similar to something like a clonidine, where it actually will affect those presynaptic alpha-2 receptors that decreases the amount of norepinephrine, epinephrine being released. So it's a sympatholytic, decreasing sympathetic output from that standpoint, so that'll help to decrease the blood pressure and the heart rate. Other drugs you're going to be seeing used as well include things like calcium channel blockers. Typically, these are going to be your dihydropyridines, because a lot of these patients don't have issues with contractility of the heart beating too fast. A lot of times it's just the blood pressure. So you can use dihydropyridines, which are working more peripherally, help decrease that blood pressure. And we'll see another place where these can also be useful as well. And then if you were needing rapid management of this on the inpatient side, this is where you can use drugs like nitroprusside or nitroglycerin, which are direct vasorelaxers, to help deal with the acute management of that blood pressure. So again, those would be more kind of emergent situations. So next, we'll mention gestational diabetes. So this is going to be any degree of glucose intolerance that's brought about during pregnancy, and again, affecting around 7% of patients. And really, most women need to be screened usually around 24 to 28 weeks of gestation. You can see that a lot of this will resolve after delivery, but some women will actually be at risk for developing type 2 diabetes later on because of this. So how do you diagnose gestational diabetes?
Through OGTT.
Yeah, the OGTT. So I only mention this because it is technically kind of a drug. We stock in the pharmacy at least when we do our OGTTs for peds patients. But we will have basically this really sickeningly sweet glucose solution that these women have to drink. And basically you can do a couple different methods. I don't know that one's necessarily better than the other. Some patients will do a two-step method where you'll do a 1 hour glucose challenge with 50 grams of glucose. Some of them will do, and then next you would do a 100-gram challenge with a 3-hour glucose check. So again, you're waiting an hour, checking their glucose, and if it meets certain thresholds, you could say yes, they have gestational diabetes. The easier thing to do, which kind of saves time for your patients, would be to do just a 1 hour, a 1-step 2-hour OGTT where you give 75 grams, and if they meet a certain threshold, then yes, you have gestational diabetes. You can also diagnose this based on things like your A1C, fasting glucose, and things like that. You may not necessarily need the OGTT if they have kind of a smoking gun in some other respect. So obviously dietary modification is going to be the best thing to help correct the blood sugar. So again, using say fewer carbs and things like that. But if you need to use medical management, insulin is going to be our drug of choice. Again, this is probably the most natural product that you can use because the body already produces insulin anyway. So we know this should not have negative effects on the fetus. So this is actually a category B drug. So the nice thing about insulin is because it's a protein, it's a large molecule, also doesn't cross the placenta all that too easily. So again, limits the amount of exposure that the fetus might have. There are a couple other drugs. We'll talk about these in the endocrine sections. Things like glyburide, which is a sulfonylurea. It's a class of drug that actually will stimulate the pancreas to release its own insulin. This one will be used somewhat sparingly. Say if a patient could not receive insulin, or if they were not willing to, say, give themselves injections and things like that, because obviously you can't use oral insulin, it doesn't get absorbed very well. And then metformin is another one that is useful to use because it works as an insulin sensitizer. So basically whatever insulin the patient's releasing, the metformin helps to allow the liver and the skeletal muscle to uptake it a little bit better and decrease the blood glucose concentrations. This one appears to lack teratogenicity and may be used as well. But again, most of the time they're just going to be put on insulin for the duration of the pregnancy. Okay, and then looking at thromboembolism, so we see that the risk of VTE is going to be increased 5 to 10-fold in pregnant patients. Here, we're going to see that our drugs of choice, bless you, we already know that Warfarin is going to be a category D drug. It's not really going to be useful for our patients because it's going to mess up their vitamin K synthesis. It's not going to be good for them. So what we can use are going to be some of our heparin products. Again, heparin, if you remember the chemical structure of that, it's a long sugar molecule. And then you remember that our low molecular weight heparins are just kind of chopped up heparin molecules. They have a hard time crossing that placenta anyway, right? Because those molecules are very large, hard for them to cross. So any reason why you think that you might want to use, say, something like enoxaparin over, say, unfractionated heparin? What was that?
It's lower molecular weight.
So it's a lower molecular weight.
The short half-life.
So low molecular weight heparins have a longer half-life than your unfractionated heparin. So usually if you're looking at, say, and how do you have to give this medication?
Sub-Q.
Yeah, sub-Q. So again, for prophylaxis purposes, you're typically giving these drugs subcutaneously. Again, this is going to be chronic. So again, for the duration, especially if they're at very high risk, if say they have some sort of clotting disorder beforehand, they have hypercoagulability already, you may put them on this kind of prophylactically. So unfractionated heparin, usually when it's being given as a prophylactic, you would be giving it, say, 3 times a day because it's a shorter half-life, give it every 8 hours. Versus something like low molecular weight heparins like enoxaparin, those have a longer half-life, and so for prophylaxis you can get away sometimes with just twice daily dosing, sometimes with once daily dosing, which obviously is going to be much preferred to your patients because they can just give themselves 1 shot a day versus 3. Right? So that could be a big patient satisfaction point there. And again, they're going to be working very, very similarly to one another. You normally don't have to do a lot of monitoring with these if you're just using it for prophylaxis. So for instance, with unfractionated heparins, how would you measure the anticoagulation effects of it?
PTT or PTI.
So for unfractionated heparin, you would be using PTT, right? Your APTT. That's what you're monitoring for to see how well you are anticoagulating the patient. Anyone remember how you do it with enoxaparin? Yeah, you use anti-10A levels, right? Because if you remember that their mechanism of action is a little bit different because heparin is going to be working on factor 2 and also works on factor 10 to a large degree. There's a few other factors it works on. But remember, it's enhancing the effects of antithrombin 3 to help degrade those clotting factors down. If you look at something like a lower molecular weight heparin, like enoxaparin, you're working much more preferentially on factor 10. You lose all that factor 2 ability. So because of that, APTT is used for heparin. Anti-factor 10A is going to be used for enoxaparin. But for prophylactic purposes, you typically don't need to do a lot of monitoring for that. So again, that's another benefit for these patients. However, warfarin is not going to be recommended because we know it's a known teratogen. I'm not really sure of any specific situations where you would want to use it, but perhaps an OB-GYN or a hematologist would have a specific situation in mind where it could be utilized. But basically, though, if they have a VTE, you want to continue treatment throughout pregnancy and then 6 weeks after the delivery. So oftentimes they'll be used for a minimum total of 3 months because there could be some lingering hypercoagulability as a patient is postpartum and they're still kind of getting back to their baseline, right? So just be aware of what the monitoring parameters are going to be, know how those mechanisms are a little bit different and why we might choose enoxaparin over heparin for our patients, right? So one's not necessarily better than the other, but usually low molecular weight heparins have the benefit of using less frequent dosing. Okay. If they develop some acute conditions like things like UTIs, you definitely always want to treat this even if it is asymptomatic. Some of the common drugs you're going to see being used include nitrofurantoin. I probably didn't talk about too much of this in the ID section, but these are frequently used for UTIs. Some patients who need kind of chronic prophylaxis of UTIs will use nitrofurantoin. This one's working by inhibiting bacterial carbohydrate metabolism and then can also disrupt the cell wall. The only problem here is it does not cover Proteus, so if they had a UTI that was from this, the drug would be ineffective. So that could be one shortcoming of the drug, but it's category B, used very frequently. You could also use things like cephalosporins, things like cephalexin. All those drugs are safe for pregnant patients. Amoxicillin could be used as well. Always worry about increasing resistance, so especially with things like E. coli. Nitrofurantoin usually retains some activity towards E. coli as it get more resistant, but amoxicillin could lose activity pretty early on. So it just depends on your patient what the local sensitivity patterns are going to be for your population. And then all of them are also going to be compatible with breastfeeding, so they're okay to use as well. As far as pain goes, so if a patient does have pain, obviously you want to tell them just to just tough it out, just man up, right? Just kidding, you don't want to do that. Not your pregnant patients, they're in pain. So you can use things like acetaminophen. That's probably going to be the drug of choice. It's category B, also good for fever. It can be utilized. NSAIDs can be used early on in the pregnancy, usually in the first or second trimester, but they become a category D during the third trimester. And that's because it can close that ductus arteriosus early, which can be problematic for your peds patients. So again, have you guys covered any like pediatric cardiology and how blood flow occurs in the fetus? Very different than an adult patient, but if you close that early, you kind of close the ability for that mixing to occur between the venous and the arterial sides. And so interestingly enough, if you have a neonate who's been born that has not closed off that ductus arteriosus, that's actually the drug you use. We'll give IV ibuprofen or IV indomethacin to actually close that up. So that's a frequent thing you'll see used in the NICU. But in pregnant patients, you want to avoid that in the third trimester. You can also potentially use a drug like morphine to help with pain. It's considered category B during the first and second trimester during short periods of time, but if it's used as a prolonged chronic therapy, if it's used at high doses, it can become category D. And so what do you think are some of the issues with giving morphine to some of these patients? Addiction. So yeah, so you can certainly have addiction problems in the mother. Usually if you're treating acute pain issues, like you don't really worry about addiction developing. Certainly it's a risk. The problem you run into with kind of chronic use of opioids is that the baby's being exposed to this throughout the pregnancy. When the baby's born and all of a sudden you cut off their source of the opioids, you can run into some withdrawal issues. So we'll talk more about this when we talk about pain management stuff in the next section. But essentially, these withdrawal problems can occur. We see this a lot in mothers who are abusing other drugs, illicit substances, so certainly cocaine. You can see this with patients who are using SSRIs, or selective serotonin reuptake inhibitors, which are utilized for depression. Anytime you're chronically exposing patients to these drugs and all of a sudden they come out of the womb and now they're not being exposed to anymore, they can have these withdrawal effects. And those are probably the most common ones. You'll hear the term NAS, or neonatal abstinence syndrome, and that's what that is. So it's not uncommon for mothers who are abusing drugs throughout the pregnancy, say they're abusing morphine or Oxycontin or whatever you want it to be. The baby's born, now all of a sudden they get very, very cranky, they're having all kinds of cardiovascular instability, they're sweating, they're crying constantly. A lot of times it's due to that withdrawal effects. And so very frequently if you ever see a neonate who's on methadone, that's probably what it's being used for, because it's a long-acting opioid that can help kind of wean them off. So you don't have to memorize that, but just know that That's why it becomes a category D when you're using it for long periods of time, because you worry about the withdrawal effects from the fetus once it's born. So, and again, looking at the mental health aspects of treating these pregnant patients, so we can see psychiatric illnesses affecting about 500,000 pregnancies each year. We see that anxiety disorders and depression are probably going to be the most common ones you're going to run into, and that we'll see that many women are going to discontinue all therapy due to fetal concerns. So there's a lot of maternal guilt that comes into it, saying, "Oh my gosh, I don't want to take anything because I might affect my baby," because you have no idea what's going to happen 18 years from now or 20 years from now, whatever it happens to be. They get very, very concerned with any kind of drug use. But it's important that, if they have a relapse of symptoms and they get really, really depressed, that can lead to even bigger problems. So it's important to make sure you're having good conversations with your patients and saying, that a lot of times you may need to treat them with say, an antidepressant throughout the pregnancy. So, you also have the postpartum blues or postpartum depression that can develop. We'll see that around 10% of childbearing women will end up experiencing true postpartum depression, especially that first month after the childbirth. And again, because we're having higher public awareness of it, it can be treated much more easily. A lot more people are willing to talk about it and get the proper treatment for these patients. The drugs of choice we're going to use, and we'll talk about these when we get to the behavioral medicine section, but we're going to be using our selective serotonin reuptake inhibitors, or SSRIs. These are the kind of the newer class of antidepressants that have a much better safety profile than a lot of the older drugs we used to use. They're very, very effective for treating depression for the most part, and we're actually having expanded literature because we have more women who are taking these drugs during pregnancy, and we have these registries, these voluntary reporting. We can get more data about how the fetuses are being affected, at least in the early term. Some of the problems, though, is we're not really sure what's going to happen, say, 20, 30, 40 years down the road. Could it be affecting them having depression, or could it be having untoward effects that we don't even know about? So a lot of the long-term studies aren't there, but again, for treating the acute issue of depression in the pregnant mother, it's probably an okay thing to use. And so, again, we mentioned that very few adverse effects have been reported with SSRI use during pregnancy, but you do have the possibility for withdrawal syndrome. So that's actually an interesting case I had during fellowship, where we were called over to the NICU because they really weren't sure. The baby was maybe only a few days old. Really was just having all these weird symptoms. The physician couldn't really figure out what the heck was going on with the patient. So we actually were looking at the mother's medication profile and saw that she'd been taking Zoloft throughout the entire pregnancy. And so now that the baby was not having exposure to that anymore, chances are these symptoms were related to that, right? So you don't necessarily want to start the SSRI and the baby back to deal with that, but there are some other methods you can use to help kind of calm and soothe the baby and deal with some of those symptoms, which we won't get into here. But just be aware that those withdrawal effects could occur potentially. Obviously, the mother is still breastfeeding continually, then that will still allow the fetus to get some exposure to it, so it may help to ameliorate some of those withdrawal symptoms. Example agents we might use, this is not an all-inclusive list, but there are some ones that you'll see used commonly, include ones like citalopram and escitalopram. Do you guys know how those two drugs are related? You had to guess? Right, so citalopram is going to be that racemic mixture, right? So you guys remember there's left-handed and right-handed chirality of molecules. So escitalopram is just one of those handed sides of that. Basically, they just took that out to try to maybe limit side effects, or probably to get a patent extension, whatever it happens to be. But those are two common ones. Paroxetine or Paxil is another one. We'll see that fluoxetine is nice because it's a very long half-life. So again, if you were to have a fetus born, they would have kind of a natural taper off of their own blood levels that help to limit some of those withdrawal effects. Again, we're finding new things as we go along. So for instance, you see something like paroxetine have a 1.2 to 2-fold increased risk of cardiac malformations in the first trimester, right? So that risk may still be low, but it has definitely increased from what someone who's receiving no drug whatsoever. So we're still finding these things out as we go along. I think sertraline is also going to be another one. Sertraline or Zoloft is one that's frequently recommended by a lot of OB/GYN practitioners as well. So if you cannot utilize an SSRI, tricyclic antidepressants, or TCAs, can be used as well. These are older antidepressants that are going to have more side effects because they have kind of kind of more wide-ranging receptor activity. So really the SSRIs are working specifically to block reuptake of serotonin, so you have more serotonin sitting in the synapse, right? We'll talk more about the details of that mechanism, but when you have TCAs, they do that, but they also have effects on antagonizing muscarinic receptors. They'll antagonize histamine receptors, alpha receptors, so a lot kind of dirtier pharmacology, so to speak, and so you're going to see more side effects. These are why these are used as second-line agents. Common ones you'll see being used include things like amitriptyline, nortriptyline, disipramine, probably some of the more common ones you might have heard of. Okay, just to mention here, folic acid is super important for pregnant women to take because it's important for preventing neural tube defects. So again, if the woman's already pregnant, there's not a whole lot of benefit you can use from folic acid at that point, but this is why, if they are looking to get pregnant, they're taking prenatal vitamins, hopefully it's already including this folic acid requirement to help to prevent that neural tube defect. You'll also see that patients who have had an infant with a neural tube defect are going to be on a much higher dose of folic acid, 4 milligrams instead of say 400 micrograms, in order to help prevent further issues if they were to have another pregnancy. So very few women probably follow this recommendation. So again, it's really important. Take your prenatal vitamin. Make sure they're getting their folic acid in to help prevent these potentially life changing congenital malformations. Okay, so how would you want to postpone delivery? So a lot of moms just say, "Get this thing out of me." But sometimes you don't want that to happen. Maybe it's a little too early. You need more time in the oven. So we can use tocolytics to help prevent that. And so these are going to be used when there are regular uterine contractions, but you're not, and you're having these cervical changes. And so kind of 4 classes that you can use. First one are going to be the beta agonist. And so this is a drug you'll sometimes see used for, say, refractory status asthmaticus, but it's going to be terbutaline. As you might imagine, it works very similar to albuterol because it's a beta-2 selective agonist. So again, we know that by agonizing beta-2 receptors, what does that do to smooth muscle? Relaxes it, right? So just like it does in the bronchial smooth muscle, it can relax that when you're having an asthma attack. It can do the same thing to the uterine muscles, help slow down those contractions. So this one is usually either given IV or PO. It's not like an inhaled product as you would see with albuterol. Sometimes you'll see magnesium being used, but pretty has kind of limited use as a tocolytic. The more common one we see being used nowadays are going to be the calcium channel blockers, specifically nifedipine, which is a dihydropyridine or non-dihydropyridine. It's a dihydropyridine. Nifedipine tends to have fewer adverse effects for a lot of these women and appear to be more efficacious. So, for instance, one of my cousins is actually also pregnant. We have a lot of babies coming along the way. Yeah, I think I've my sister's having twins, my sister-in-law is having a baby, and then my cousin's having a baby. So we got a lot of buns in the oven. But my cousin, she was going into early contractions, so they actually put her on nifedipine to help kind of decrease that. Takes it orally every day to help kind of decrease those contractions and hopefully allow for longer time until the actual birth occurs. You may see NSAIDs being used somewhat rarely, but again, you run into issues if you use that towards the 3rd trimester with that ductus arteriosus closure. There's also progesterone you could potentially use, and so this is kind of controversial, but this is interesting. Like my sister, she had her first child, who's now 2, but had her, I think, at 33 weeks, which is that term birth, or is that premature? Yes, premature. So she spent some time in the NICU, and so in order to, because she's known high risk to have a premature baby, and now she has twins on the way who are also prone to go a little early, they actually put her on progesterone to help limit that, to help kind of keep things in kind of status quo for as long as possible, to help kind of prolong the time of gestation. And so you'll see progesterone sometimes being used intramuscularly at week 16 through 36 to help kind of decrease those uterine contractions from occurring and those cervical changes from happening. We'll talk more about progestions a little bit later on in this section, but just be aware that they will sometimes use those for high risk preterm deliveries.
Why is it controversial?
I think because the efficacy of it, there may not be a ton of data out there. Because again, it's hard to do randomized control trials to see how useful it's going to be. Prior to, there used to not actually be an FDA-approved product, so it actually was compounded at like specialty pharmacies. But nowadays there is a new product, it's hydroxyprogesterone, the brand name is McKenna, that's available now. And so the way that the FDA works is that if there's a commercially available product available, you're not really allowed to compound your own version of that, right? Because of safety concerns and production concerns and things like that. So this one is way more expensive than the compounded product would have been. So it's been some concerns for a lot of patients as whether or not they can actually get this covered by their insurances and things like that. So just be aware that's another thing that you can use to help prevent those high-risk patients from giving birth too early.
Isn't it cheaper to give this than to take care of a preterm baby?
Probably. But if you don't have a lot of evidence to say like, hey, this is truly useful, then who knows? Maybe they would have had that baby preterm anyway. Yeah. So. Okay, so what happens if you want to induce labor? So say we want to get things moving along and get this baby out of there. So these are drugs that are useful for facilitating cervical ripening and then labor induction. So you can use prostaglandins that can actually help to induce this. If you guys remember, actually we'll talk about this drug in the GI section, but prostaglandins can actually be utilized to help induce kind of a chemical abortion, basically. Sometimes for unwanted pregnancies, they would use this drug misoprostol to actually either they can use it for like an ectopic pregnancy, or if a woman's wanting an abortion, they could do it this way. Oftentimes use it with drug methotrexate. But when the baby's ready to come out, but it's not really moving along yet, you can use these prostaglandins to help kind of start the process. So you can use things like dinoprostone, which is a prostaglandin E2 analog. These are actually given vaginally, so it can be applied directly to the cervix to help kind of start that ripening process. This one is removed either when labor begins or say after 12 hours. And you have to also monitor the fetal heart rate because it can cause some changes there. So it's important the monitoring is followed there. And then misoprostol is just a prostaglandin E1 analog. You may see sometimes be seen used in NSAID-induced ulcers. So that's kind of the other common place to see it being used. But here you can use it for labor induction as well. And then probably the most common one is going to be oxytocin, or Pitocin is the brand name there. Most commonly used agent. This is going to be given as a continuous IV infusion during the labor. This one acts as the endogenous oxytocin that your own body produces, right? This is kind of that love chemical that helps increase that bond between the mom and the baby. But basically, when the mother is getting ready to give birth, she has upregulation of those oxytocin receptors. So by giving exogenous oxytocin via the IV, we can help to stimulate those receptors and kind of get things pushed along. So it helps to facilitate the uterine contractions. And there are a few adverse effects you can see potentially including PVCs, or premature ventricular contractions. It can occur in either mother or baby. And they can actually see risk of bleeding due to afibrinogenemia that can occur somewhat rarely. So again, rare side effects, but something to be on the lookout for. Okay, as far as labor pain management goes, we'll talk more about this later in the pain management section, but very frequently, how are pregnant women, how is their pain managed during labor? An epidural. Why would you use an epidural?
Stops all the pain from the waist down.
Stops the pain from the waist down.
It allows you to push. Can they still push and function a little more?
Usually they can still push and function. We'll see that it depends on the level of analgesia that you're applying. But the nice thing about giving a drug epidurally is that you limit systemic exposure to the fetus, right? So if very frequently you're using ropivacaine and fentanyl, sometimes bupivacaine. Those are both local anesthetics that when given via the epidural route, again, based on how far up the spinal column the drug is administered and how far the drug goes, basically limits how far the analgesia goes, right? So essentially, you want it basically from the waist down to where the mother is still able to give, still able to push, still feel some stuff, but she doesn't really have the same pains associated with it as she did prior to the actual epidural being given. And so, if you were to give that systemically, one, bupivacaine is highly cardiotoxic. So it can actually cause cardiac arrest pretty significantly. So we don't want to give that systemically. And then also, if you were to give the fentanyl systemically, fentanyl being an opioid, does anyone know a common side effect from giving opioids? Constipation, yeah, but it's more life-threatening.
Decreased respiratory rate.
Yeah, so decreasing their respiratory drive. So if I were to give that systemically, and I could decrease that fetus's respiratory drive when it's born, it may go apneic, right? So you wouldn't want to do that. So by giving it the drug epidurally, you're giving it to the mom and only the mom, right? And by limiting that systemic exposure. So adverse effects you can see with this, including things like hypotension. We see some pruritus and inability to void, because again, they may not feel that actual need to void. Oftentimes you'll see catheters that are being placed during the duration of having the epidural in, so that way they can just, they don't have to worry about that. You can actually see prolongation of the first and second stages of labor as well, because again, if you're not really, the way our gynecologist our obstetrician had described it, she said, man, if you did not have this epidural, you would have had this baby like 8 hours ago, because the pain is so intense that you're just like, get this thing out of me, versus you're like, oh, this isn't so bad. You may sit around for a little bit longer period of time. So that made sense in my mind. So you can see prolongation of those stages of labor. And then you also run the risk of having a spinal headache due to a puncture of that subarachnoid space. So as we're having a really good CRNA, to place the epidural can be very useful to help prevent those headaches. So I know my dad, he's a CRNA. He's been doing it since probably the 70s, and he has given so many epidurals. He worked in labor and delivery for like 20 some odd years, that he was everyone's favorite guy in the entire hospital. So most of the women who had their babies there had their epidurals done by my dad. So they're like, your dad's so great. He's wonderful. And I'm like, this is weird. But he was Mr. Feelgood, because basically got rid of all that labor pain. So the other thing was, another kind of funny story is that you're looking at the vital signs for the mom as well, because you can see hypotension, some bradycardia. When my wife was receiving her epidural, heart rate started to dip down a little bit, kind of into the 50s, and I was like, I don't know, I think maybe they should probably turn down your epidural a little bit. And she said, if you tell them to turn that down, I will snap your neck. And I said, okay, heart rate looks good to me. So, and it's also oftentimes it's via patient-controlled analgesia, or PCA format. So basically, they will have a button they can press if they need a bolus dose. We'll talk more about PCAs in the pain management section, but just be aware that frequently it's usually set to have a basal rate or a continuous infusion of drug, and then they can also press a button to give themselves a little bolus if they need the additional analgesia. So, okay. Moving on, the next thing we'll talk about are going to be our estrogens and progestins. So this is where we talk about things like oral contraception. This is where we talk about hormone replacement therapy. This is where I'm very much out of my field of expertise, because again, as I mentioned, I don't know how women work, so. But I can at least figure some of this stuff out. So basically, when we are giving exogenous estrogen and progestins, we're trying to help either replace the normal physiologic amount that the body would have been producing anyway, or we are trying to help to inhibit this whole system, right? Especially if we're trying to prevent pregnancy, like we want to shut this whole system down, basically. And so this is being regulated at a couple different steps. First, you have the hypothalamus, which is releasing that gonadotropin-releasing hormone. That is helping to stimulate the pituitary gland and producing two different hormones. We have luteinizing hormone and follicle-stimulating hormone. As you might imagine, what FSH does, probably stimulates follicles to produce, right? So those are both going to have positive effects on the ovaries to produce things like estradiol and also progesterone, right? So you kind of have these multiple steps here. And the way we shut this system down is by negative feedback inhibition, right? So that's once we have sufficient blood levels of estrogen and progesterone, they can affect the hypothalamus and they can affect the pituitary gland and say, hey, we have enough estrogen, we have enough progestin, let's shut things down for a little bit. So it can help to limit the amount of luteinizing hormone and follicle-stimulating hormone that's being released by the pituitary gland, right? So essentially that's what we're doing. So in hormone replacement therapy, say the ovary is not producing enough of its own, so we're helping to replace that. But with oral contraception, we are giving a high enough dose of these potent steroids to help to shut down the pituitary gland so it does not release the LH and the FSH, so that way we are not having the conditions set to have a pregnancy, basically. So I like this graph here. It kind of gives you a good example of what's happening during the menstrual cycle. So you can see, and I'll get the laser pointer. So basically you can see kind of the stages of what's happening throughout the 28-day period. You can see the endometrium, how it's developing. You can see here how the follicle is kind of developing and how the ova is being released and then eventually deteriorating if no pregnancy actually occurs. And you can see how the hormone levels are going to be changing based on this as well. So this may be all news to the guys in the room. Girls probably know all this, right? I don't know. So anyway, if you're looking at your LH, which is going to be this dotted line here, and the FSH, which will be the solid line, you're going to be seeing here that around day 14, this is typically what happens around this stage? Ovulation, absolutely. So this is where you have a big stimulation, your LH and your FSH occurring. You have a big spike. That's where the chances for pregnancy are going to be most likely at that point. That's where the ova has kind of been released and it's kind of ready to go. You'll also see this is where the stimulation by the LH and the FSH on the ovary is causing the estradiol levels to peak up here. And then you'll actually see a little bit later on, the progesterone is going to be peaking up later in the phase. So if no pregnancy actually occurs, the progestin helps to limit, it kind of helps to return things back to normal to the beginning of the cycle, helps to get that endometrium kind of back to its baseline. Because if you had unopposed estrogen stimulation, the endometrium would just keep developing and developing, and you run the risk of developing cancer, right? So that's where we're going to see that for patients who have, an intact uterus, if you have unopposed estrogen effects, you can run the risk of having increased risk of endometrial cancer. So that's one of the big things we'll talk about is when you need to use a progesterone in addition to estrogens, or if you can use an estrogen by itself. And that'll depend on your patient and what her kind of her uterus status is going to be. Make sense so far? All right. So we know that disturbances in ovarian function can be pretty common. You can see it being due to inflammatory or neoplastic processes. So if you have issues like this, it can be affecting the uterus, the ovaries, and or the pituitary gland. So kind of all steps in the process of producing estrogens and progestins can be affected here. Usually minor disturbances are going to be pretty self-limited. As you might imagine, things like emotional or physical stress can affect gonadotropin releasing hormone levels. Extremes in diet or exercise can also affect this. So I always think about the really skinny cross-country runners, how they can go in basically amenorrheic for a period of time during the season because they are running constantly, very, very skinny. So basically their body's not in a stage where they are trying to get pregnant, so they don't really need that. But once they go back to normal, then they can develop normal menstrual cycle again. So that's definitely possible to occur, not necessarily a sign of a more systemic problem. So looking at the estrogens that we will be using in our patients, we have natural estrogens that are available. So we have the major ones that are being produced in women include estradiol. This is going to be one of the major secretory products of the ovary. And you also have estrone and estriol. And these are being converted either in the liver or the periphery. We're going to see that the liver is really important for metabolism and excretion of these hormones. We'll also see this is where some of the side effects can come from, specifically our thromboembolic side effects we can see from estrogen. So keep that in mind in the back of your head. Other natural ones you might see being used include equilin and equilin, and these are actually captured from horses. So if you ever see the drug Premarin, that actually comes from the term pregnant mare urine. So basically you can actually capture these up in the pregnant mare's urine, extract it, and then we can use that as a pharmaceutical product. So I always thought it was probably one of the more interesting drug sourcing bits of trivia. So next time you see someone taking Premarin, you'll be like, oh, you're taking horse urine. Good job. Anywho, so you can see how the different changes in the hormones are occurring. Again, this is a multi-factor process. You'll see here that you'll have, due to either the follicular phase or the luteal phase, different progestins and estrogens being produced. Notice here we have these kind of precursor molecules. So this androstenedione and testosterone, which gets converted into that. The important enzyme here is going to be aromatase. And we'll see that aromatase inhibitors are going to be useful for things like breast cancer. So we're going to see a lot of those being used. Probably talked about those in the previous sections. But essentially we're producing our estradiol, producing our estrone, and again, those can get converted over into other products as well. So there's a lot of cross-conversion of these hormones that are occurring, some of which is happening in the ovary, some of which is happening more in the periphery or specifically in the liver. So the synthetic products you're going to see used most frequently are going to include, most frequently see ethanol estradiol. It's a very common one. You can also see other varieties of their salts of estradiol being used. And then also conjugated estrogens can be used as well. So it's usually kind of a mixture of a lot of different products being utilized all at the same time. So again, I'm not going to get super in depth on memorizing all of the brand names for these drugs or getting the different varieties, because I included, if you look on the site, there's a oral contraceptive comparison chart. There's a lot of brand names out there for all these different drugs, and so it's very easy to get lost in trying to memorize any of those. So just be aware, just be able to identify one of these drug products and be able to recognize, yes, this is an estrogen-based product, right? Be able to see that, okay, ethanol estradiol, I know that's an estrogen, I know these things about it as we go forward. So looking at the pharmacokinetics, these are highly protein-bound products, bound to either albumin or sex hormone binding globulin, is majority there bound. And again, we see this peripheral conversion of the estradiol to estrone and estriol, and either in the periphery or in the liver occurring there. Big thing to note here is that the conjugated metabolites that are produced in the liver get excreted in the bile. So this is where we see some of the side effects can occur. This is where we also see an interesting pharmacokinetic phenomenon happening here called this enterohepatic recirculation. And so essentially what we see is that when the products that are conjugated get spit out into the bile, they go into the GI tract, and then there they can be hydrolyzed back into an active product and be reabsorbed. Right? So this is why, even though you may see a certain half-life for some of these drugs, they actually have a much longer duration of action than you would expect based on this enterohepatic recirculation that's happening there. Right? So it's basically extending the duration of action of the drug by reabsorbing it as it gets recycled. And so when you're giving these drugs orally, you can see that they have a high ratio of hepatic to peripheral effects versus if you were to give something, say, vaginally, if you were to give something topically, you're going to see that the side effect profile changes pretty significantly. So again, orally based products are being absorbed. First organ they're going to hit is going to be the liver. So again, you're going to see the side effects there. If I give it via injection, transdermal, vaginal, I can limit some of those systemic side effects, or basically the liver-based side effects, and just get more kind of locally working actions. So we'll talk about different drug products where you might use one versus the other based on your patient's symptomatology. So how do the estrogens work once they're produced? Essentially, just like any other hormone out there, they're going to be crossing into the cells, depending on what type of cells they're going to, whether it be breast tissue, endometrial tissue, the liver, skeletal muscle. They're going to get down into the nucleus of the cell, and there they're going to be binding over to these estrogen receptors. And you're going to see basically that there are mixtures of different types of receptors. So for instance, the hormone complex forms these dimers of estrogen receptor alpha, estrogen receptor beta, and based on the type of tissue, you're going to see different conformations of those, where you might have two alphas, you might have two betas, you might have an alpha and a beta, and you can have different effects from these estrogen-based products. This is where when we look at our selective estrogen receptor modulators, we'll talk about those later, but basically they can have different effects in different tissue, to where in the bone they may act as an agonist, whereas in the breast tissue they'll work as an antagonist. And a lot of it's based on this receptor morphology and based on what type of receptors they're going to be hitting in different tissues. But once they form these dimers, they're going to bind to these estrogen response elements, and that way they can start to regulate transcription of various genes. They can start to produce different products. So say in the liver, they may affect the production of clotting factors, right? Say in the bone, they may help to limit the amount of bone resorption that's occurring. They help with things like osteoporosis. So again, just be aware that the effects in the different tissues can be affected by not only the receptors they're binding to, but also some other co-regulators that will be involved there. So, clinical effects that you would expect to see from estrogens, certainly female growth and sexual maturation, so this can help to stimulate development of all the sex organs. You'll also see that this can affect the bones as well, so it can help with the growth phase and also the epiphyseal closing of long bones at puberty. This is where it also can affect things like body fat distribution and hair growth. And then as far as endometrial effects, we'll see that estrogens have kind of pro-growth effects on the endometrium. Again, this is where we worry about our cancer risk as well. But essentially, by interacting with progesterone, this is going to encourage that regular kind of bleeding and shedding of the endometrial lining. So progesterone is really going to be effective for that. So you have the estrogens kind of peaking early, and then you have the progestins kind of peaking a little bit later than that to help kind of stimulate that recycling of the endometrial lining. It's not really recycling, but the shedding of the lining. But again, continuous exposure to estrogen alone leads to the hyperplasia and also abnormal bleeding. So it can be, we'll look at different side effects, and you can actually, based on when the side effects are occurring, especially abnormal bleeding, you can determine whether or not your dose of estrogen is either too low or your progesterone is too low. And we can actually determine how you can change their dose of their, say, oral contraceptive based on that. So we'll look at that a little bit later. Other metabolic effects you can see, this helps with normal structure and function of skin and blood vessels. Helps to decrease bone resorption. So this is really, really important for osteoporosis prevention because it helps to stimulate the apoptosis of the osteoclasts, which we know are useful for kind of starting to demineralize the bone to liberate calcium. But here, estrogen is going to help prevent that. So it helps to keep the bones nice and strong. It can also antagonize the parathyroid gland. So it helps to prevent parathyroid from really spitting out a lot of PTH, which helps to stimulate that bone resorption. We'll also stimulate adipose tissue development. We can actually see higher serum protein levels due to some of the liver effects, and they can actually have some effects on your lipids as well. So kind of positive effects, including increasing your HDL and reducing total plasma cholesterol. So there's going to be some positive effects from that standpoint. In the liver, you're going to see these coagulation effects. So like I mentioned, you're going to have enhanced coagulability because we know one of the big side effects from oral contraceptives is blood clotting, right? The blood clots can be potentially fatal, but these are due to increase in the production of factors 2, 7, 9, and 10. You remember this is also the specific factors that warfarin is going to be affecting as well. This can also work to decrease the activity of antithrombin 3, which we know is really important for helping to decrease a lot of those, the activity of those factors. We'll also see that the estrogens can help to affect mood and libido, and can also, due to some mineralocorticoid effects, help to produce edema and some fluid retention, right? That's when you see natural changes in the amount of fluid retention that occurs in females. A lot of it's due to the estrogen effects throughout their normal cycle. So I think I'm going to go ahead and cut it there. We will come back and talk about the rest of this stuff on Thursday. So any questions before I let you guys go? Yes?
So some of those positive clinical effects of estrogen aren't seen if you give it like exogenously after they go through menopause. Do we know why?
How do you mean?
Like estrogen is supposed to be cardioprotective.
Mhm.
If you give hormone replacement therapy, it doesn't show that it is. I guess there's research on both, but I thought that it shows that it's not cardioprotective if you give it after menopause.
Yeah, so I think a lot of it has to do with competing factors, because again, based on the tissue that the estrogens are working in, you're going to see different effects, right? So on one side, you may have some positive effects on serum lipids, but on the other hand, you have clotting effects, right? So you're kind of, how do you tip the scales depending on how your patient's more prone to, are they more prone to atherosclerosis and having a clot? Maybe they're more prone to having one of those outcomes. I think there's a lot of kind of mixed signaling that's out there. I think overall, though, they find that it's probably not super cardioprotective in the long run, or at least it's somewhat controversial. It's not like you would see like a home run like you would for like osteoporosis, or by the positive associations like endometrial cancer, things like that. So it's complicated, basically. Any other questions? Okay, all right, well, I'll see you guys on Thursday.